Okay, we're going to start chapter 24, and this is our last pulmonary lesson. Yay! Although I like the pulmonary section, and you'll find out that when we get to Med-Surg 2, that every single week we'll be doing a new system, and so we're not gonna spend 4 or 5 weeks just on one system. It's just that the cardiopulmonary system is so involved and affects every other system. That's why it takes so long to go over the pulmonary, and then we're going to spend about that much time in cardiac. So let's finish up pulmonary. This is kind of a short chapter. This should be a fairly easy week for you guys. And it starts in on page 618 of your book. We're going to talk about COPD, super common chronic pulmonary condition, bronchiectasis, asthma. Oh, I forgot to get my stuff. I'll run in and grab it, and then I'll show you what it looks like in a minute. I was going to bring some inhalers to show you what that looks like. So, because as a nurse, you need to be able to teach your patients how to use inhalers. I don't know if you went over that in pharmacology, but we'll go over it. So, and then lastly, cystic fibrosis is a genetic disorder also affecting the pulmonary that we're going to talk about. So let's start in with COPD. Stands for chronic obstructive pulmonary disease, and everybody just calls it COPD. So you'll need to know what that means. Chronic, obstructive. Obstructive is, like when they say obstructive, it means airway obstruction. Pulmonary disease. COPD is predominantly caused by smoking. It's a chronic disease. It comes on insidiously. When I say that there is a disease that's insidious, that means it sort of creeps up. Like, I don't know if you've ever seen the movie Insidious. It's not like that kind of a thing. It's like kind of creeps up on you really slowly. That's what the word insidious means. COPD is insidious. And it's usually composed of two different diseases. It's a combination of chronic bronchitis and emphysema. So, and you can read about it in your book. When somebody's had chronic bronchitis for several years, and they start developing emphysema, and they've had that for a while, the combination of two, then you get a diagnosis of COPD. So it's not like you just wake up one morning and have COPD, kind of like you might with pneumonia. It's not like that with COPD. Now, a couple things with COPD. There is an inflammation in the lungs. There's usually a lot of exudate. By exudate, I mean sputum, stuff that's coming up from the airways. Your patient will cough a lot. And there's a loss of elastic recoil. If you remember that we talked about the pulmonary system to be functioning healthy, has to have nice elastic recoil so that when you breathe in, it stretches out. When you breathe out, it contracts back in. You need that for healthy functioning. You lose a lot of that in COPD. You lose a lot of that elasticity in a lot of these chronic pulmonary diseases. Now, here's the thing with COPD. COPD, what happens is because there is a lack of expansion in and out of here, these alveoli start getting kind of bulbular like this, and you can have panbulbular or central bulbular, where they kind of, and there's pictures of these in your book, where these alveoli start kind of blowing up. And what happens is the carbon dioxide gets trapped in here and it can't get out. One thing, you got these inflamed airways, then you have these alveoli start blowing up, kind of, which you'll see it causes barrel chest. So when these start blowing up, it starts retaining CO2, and then the patient starts getting barrel chested, we talked about. They also have dyspnea. It's difficulty to breathe. The problem becomes CO2 gets trapped in here and it can't get back out. So there's a couple of things that you'll start noticing your patient doing. One is called pursed lip breathing, and you'll see a COPD or they'll like that. They purse their lips and they breathe out through their lips. It's kind of like breathing through a straw. The reason they do this is it's kind of like doing like manual PEEP. It forces positive end expiratory pressure, because if you purse your lips and you force it out like that, those alveoli have to stay open, and you get a little bit longer of a carbon dioxide oxygen exchange. So they'll do that pursed lip breathing. You don't want to stop that. That's a good thing, because it helps get rid of the CO2. So that's common. You'll see some clubbing of the fingers in a lot of these chronic conditions. You might start seeing the clubbing of the fingers. That's an indication of a pulmonary problem. The other thing that you need to be really, really careful about in your patients who have COPD is that because they retain CO2, they learn to live with higher CO2 levels. And you'll recall that your normal CO2 is 35 to 45. They start living up in the 45 to 60 range, and their body adjusts to that, and they are usually in respiratory acidosis. Those carbon dioxide levels are high. You'll see those bicarb levels also getting high, because the bicarb is trying to compensate for higher levels of CO2. And that's okay. Here's the thing that you need to worry about as a nurse, or just be cognizant of as a nurse. The normal response to breathe, you and I take a breath because our CO2 levels get too high. So our CO2 level will start heading towards the high end of in the 40s, 45, and that hypercarbia, too much carbon dioxide, sends a signal to our brain, time to take a breath. And so then we take a breath. That is the hypercapnic drive to breathe. That's the standard, that's normal. Well, in a COPD patient, when they have high CO2 levels all the time, that drive to breathe gets wiped out, because they have high CO2 levels all the time. So that drive then kind of goes away. So what makes them breathe is hypoxia. The hypoxic drive to breathe is sort of the backup plan. So if the CO2 levels in a normal breathing person gets too high and causes you to take a breath, if for some reason you can't do that, like if you're drowning or holding your breath, the secondary thing that triggers is hypoxia. Now all of a sudden your oxygen levels are getting too low, and that'll trigger you to breathe. That secondary drive, the hypoxic drive, is the only drive that your COPD patient will have. So if your COPD patient comes into the hospital in distress, and you slap them on 6 liters of oxygen or 100% Venturi mask or something like that, and you raise their oxygen level, you'll just wipe out their entire drive to breathe. And because the hypercapnic drive is already gone. So then if you raise their oxygen levels too high, they never recognize that they're getting hypoxic, and then they don't breathe. So you need to be very careful in your COPD patient that they will need some oxygen, but not a lot of oxygen. So the COPD patients are typically on maybe 2 or 4 liters of oxygen, low levels of oxygen, because you want to help their hypoxia, but not so much that it wipes out their breathe to drive. So if your patient comes in and you put them on some oxygen, all of a sudden you see that they're getting more distressed, you might want to turn down the oxygen, which is counterintuitive, but if just keep that in mind. So the other thing in this condition is that because the pulmonary system gets fibrotic, what can happen in here, and these are the airways, this is my little heart here, and this is the vascular system. This starts getting really tight and hard, so that can lead to pulmonary hypertension, like we talked about. I can't remember what we talked about, but I know I've told you guys about pulmonary hypertension. So then what happens is the right side of the heart is trying to get blood into here, but this system is really fibrotic, and it's really hard to get the blood in there. So then it starts backing up on the right side of the heart. So you start getting fluid in the right side of the heart. This is when you're going to get JVD. Now remember, we're on the venous side because it's trying to get into the right side of the heart. And when this right side of the heart starts failing, it's called cor pulmonale. I think we talked about this yesterday. Pulmonale, A-L-A. That's right-sided heart failure, and that can happen when you have pulmonary hypertension and long-standing COPD. So you need to be aware of that. Start watching for the signs of right-sided heart failure: edema, JVD, increasing CVP, central venous pressure, things like that. So you got to be a little bit careful about that. There are a lot of medications for it. You can give medications to help expectorate sputum. You give bronchodilators, and we'll talk more about that when we talk about asthma. Bronchodilators dilate this in here. A lot of chest PT physiotherapy, PNPD drainage, some anti-inflammatories, and some steroids. And I'm going to show you when we talk about asthma. I'll probably stop it because I left them in the other room. Meter dose inhalers, powdered inhalers, aerosol inhalers. It is important to know the different kind of bronchodilators that you can give your patient, because your COPD patient will be on inhaled, it could be steroids, it can be bronchodilators. Some of them are a combination of the two. So they're going to be on some of those. If this gets too significant, there is surgeries that they can do. It's called a bulbectomy, where they kind of go in and remove some of these way too fibrotic, way too bulbous spots. So they can do that. It is important that you do encourage your COPD patient to get the flu shot and the pneumonia shot, because you really, really want to prevent any additional thing that may cause more complications in your patient who has COPD. So vaccinations, seasonal vaccinations are very important. You want to keep your patient healthy. Good rest, lots of fluids. Fluids will help get those expectorants out, but you have to be a little bit too careful if they're in fluid overload as well, if they're fluid overloaded on the right side, so you have to be a little bit careful with that. Good nutrition, lots of vitamins, lots of minerals, a lot of protein. Protein promotes healing and reduces edema. In some cases, very rare cases, they will put the patient on a lung transplant, but the patient does have to be compliant with smoking. The saddest thing, this will break your heart as a nurse, is that many, many, many patients who have COPD, they got it because they were smoking, still smoke. So they're on their oxygen and they're smoking, which is a risk in and of itself, because you've got this oxygen tank and you've got fire around it. And it is not uncommon for people who are COPD patients who have oxygen tanks to light up a cigarette, and then they end up, getting burned or something because they blow themselves up. So it's a huge safety thing that you need to talk to your patient about too, and constantly trying to get them help to try to stop smoking. Use patches, go to therapy, stuff like that. So. Anyway, so that's about it with COPD. The next thing in your book is this thing called bronchiectasis. What page is that on? There's a long section on COPD. Bronchiectasis is way over on page 631. Bronchiectasis is very similar to COPD, like the signs and symptoms are similar, but instead of this fibrotic thing in the alveoli, it's really more of a weakening in the muscular and supportive structures of the lungs, and it can lead to respiratory failure as well, but it's called bronchiectasis. The signs and symptoms will be similar. The patient will be dyspneic. They will have coughing. It's kind of the same symptoms in every kind of lung condition, but it's really more of a muscle problem rather than a chronic bronchitis emphysema problem. The bronchiectasis may end up start coughing up blood. That's called hemoptysis. That's a word you need to know, hemoptysis. So that's kind of it about bronchiectasis, not quite as common. The next thing I wanted to talk about is asthma. Now, asthma is really, really, really common. In an asthmatic patient, this is when you're going to hear the wheezing. So, and the reason you hear wheezing, I'm going to put my lungs back up here, is because asthma is always airway constriction. So asthma is a condition of the airways. Okay, this is not working out. Something like this. I don't know. Okay, so asthma is an inflammation and narrowing of the airways like this. And so when you hear air going in and out, that's what makes that sound. That's that wheezing sound. It's not a rails and crackle sounds like you get from wet lungs and fluid in the lungs. It's a wheezing thing. So the thing with asthma, it can be caused by a ton of different stuff. Some children are born with it. Some children outgrow it. Other children don't ever outgrow it. If a child is going to outgrow it, they usually outgrow it around adolescence times. It can sometimes extend into early adulthood. Some people can develop it in adulthood. It can be caused, some people have sports-induced asthma, so when they start exercising a lot, then their airways start getting inflamed. It can be triggered by pollutants. It can be triggered by allergies. It can be triggered by smoking. Certain things can trigger the asthma, so somebody might be breathing totally normal and then they hit a trigger. Certain infections can cause it, so some people, when they get like bronchitis or pneumonia, then that'll trigger the airways to start getting inflamed. The nice thing about asthma is we have really good treatments for it. We've got, you can put a patient on bronchodilators. That's an easy one. You just, the inhaled bronchodilators, and that usually opens this up pretty nicely. Some people that have more chronic conditions with asthma, they might need to also be on like a systemic steroid, but you want to treat the symptom, or you want to treat the cause. So if the cause is like, you know, an allergen or something in the like seasonal, you can also treat the patient with antihistamines in addition to the bronchodilators. If it is triggered by a pulmonary infection, you can treat antibiotics for the infection with the bronchodilators. People that have sports-induced asthma or exercise-induced asthma, sometimes, depending on how bad it is, they can just take an inhaled bronchodilator before they engage in the activity, and that's enough. So wheezing and dyspnea is really common. Sometimes, if the asthma is getting too bad, or the asthma attack is getting too bad, and usually some people with asthma, nobody really walks around with it 24/7. Usually it kind of waxes and wanes, and you know, so sometimes it's great, and other times it'll get bad in the face of whatever the trigger is. But there are certain things, and we're going to talk about this in 1 second, about status asthmaticus, which is a medical emergency. And what happens is the inflammation in the airways is getting out of control, and you can't get it back under control. And you can start recognizing that when the wheezing, you can no longer hear the wheezing, but your patient looks like they're in major distress. So if you're assessing your patient, you hear the wheezing, and then you start treating them with bronchodilators and whatever you're trying to fix whatever the trigger is, and then you start seeing that your patient is able to talk, and they're feeling better, and their pulse ox is improving, and you know, they look more relaxed. They don't look like they're gasping for air. This thing called air hunger, where their eyes get wide and looks like they're drowning. They're looking better. Then you know that your treatment is working and the wheezing is going away. But if you are treating the patient and you're hearing the wheezing, and then all of a sudden you're listening to their lungs and you're not hearing that wheezing anymore, and your patient looks horrible, they're scared, they're having this air hunger thing, and they're unable to talk, they're dyspneic, they're getting hypoxic, their pulse ox, they're desatting, and you can't hear the wheezes, it could be that this has gotten like this and you're not getting any airway in there, any air to pass through there, that's a bigger problem. Now you have a huge problem. You might have to consider intubation or something like that. I want you to look at figure 24/7. There is a couple of good care plans in here too. In this chapter, I want you to look at these care plans. Figure 24/7. Now I can't find where it is. Oh, on page, in the textbook, it's on page 640. That is a really good figure for the stepwise increments of asthma getting bad and what you need to do at each step to try to prevent it from getting worse. So I do want you to look at that, because if you can't prevent this from getting worse, it can end up causing respiratory failure. The other thing that is important in your patients who have asthma, especially long-term asthma, is they need to be on a good care plan, and usually they will be prescribed a peak flow meter. And a peak flow meter is a meter where the patient will breathe into it like really, really hard, and like you take a big breath and you force out the air as much as you can, and then you that's called your forced expiratory pressure. And there's a picture of kind of what it looks like on page 645, and you see how there's like green, yellow, and red zones. You kind of track that over time, and so if you want your patient to get into the green zone, and so if you have a known asthmatic patient, you sort of trend that and you follow where it is, and then if all of a sudden they come in and they're not doing well, and you have them use their peak flow meter, and all of a sudden it's significantly different, your patient's in trouble, and now it's time to increase medications or add a medication or something like that. So that's important information if you're taking care of an asthmatic population. And then status asthmaticus is a medical emergency. They start talking about this on page 647. Usually the asthmatic patient is in a respiratory alkalosis state because they tend to hyperventilate. They start feeling dyspneic. They feel they feel tight in their chest. They feel like their airways are narrowing, so they start breathing faster and deeper. And all these structures down here, the alveoli and stuff, are fine. They have the pulmonary structures are they're not fibrotic. They're mobile. They're flexible. But they tend to start breathing really deep, so they're blowing off a lot of CO2. So they tend to be respiratory alkalotic. In your patient who's coming in with an asthma attack, and then all of a sudden their CO2 levels start rising, even up like to the normal level, or they start developing respiratory acidosis, that's an ominous sign. Because that means now that the air can't get back out, the CO2 is getting trapped in there, and that's an ominous sign that respiratory failure is pending, and you might need to start the patient on a ventilator or something else to be able to get that oxygen exchange. So that can be kind of a significant problem. The last thing I wanted to talk about in this chapter is cystic fibrosis. It's on page 648. Cystic fibrosis is an autosomal recessive disorder. Both parents have to be carrying the disease. It's fairly common in the United States. It's more common in Caucasian people than in other cultures, and it usually means a shortened lifespan, unfortunately. Patients with CF usually they don't live past like 40, 50, 60 is really long for a CF patient. They can go on the lung transplant list. These are the patients that are candidates for lung transplants. Usually in patients who have cystic fibrosis, they also have some GI problems. They can have pancreatic malfunctions. They can have malnutrition, poor absorption problems. They can have some other problems start showing up because of this disease. And patients who have this, you really want to promote some good airway clearance, a lot of good chest PT, physiotherapy. They do have these devices that are called chest flutters, and it's almost like a vibration machine that you can put on a patient, especially like little kids, to try to get the extra secretions in the lungs, because they have copious amounts of secretions in cystic fibrosis. That's a problem, is that that it's not really an inflammation problem. It's down here, they have an overproduction of fluid. Just, you know, you're supposed to have some lubricant down here, but it's just a ton of fluid and mucus everywhere, so they cough a lot, and you really need to promote really good airway clearance in these patients. And again, good rest, good hydration, good nutrition. So yeah, read up on cystic fibrosis. And so that's it. I'm gonna stop this. I'm gonna run and grab those inhaler things so I can show you how to use those, and I can show you how to teach a patient how to use them, but I'll put that in part 2 of this. So that's it. Easy peasy, right?